So the current therapeutic paradigm relies on blocking inflammation for the most part, and there is a diverse armamentarium of drugs that are used in limiting inflammation in these patients. Starts with synthetic DMARDs, disease-modifying anti-rheumatic drugs, that include drugs like methotrexate. And for those patients that don't respond to this first round of drugs, these are then escalated through a series of therapeutics that include biologicals like anti-TNF, anti-IL-6. And this is usually done in a stepwise process where the patient is reviewed every few months to assess improvement in disease severity. In those patients where disease continues to develop and escalate and there is significant compromise of joints, and a therapeutic option to repair the damage is to replace the damaged joints through surgery. And however, the limitation to this approach is that this is only applicable to the major joints like the hip, for example, or the knees, with the smaller joints like the ones in the hands not being subject to this approach. And so patients remain disabled for the rest of their lives when it comes to the smaller joints. So in our recent work, we observed that a family of molecules, and in particular one member of this family of molecules that is termed as Maresin conjugates in tissue regeneration, was significantly reduced in patients with rheumatoid arthritis when compared to healthy people. And that there was a significant relationship between the levels of the third member of this family, which we call MCTR3, and disease severity in patients with arthritis, as well as with the development of joint erosions. And when we evaluated the biology of MCTR3, what we observed is that at variance to many of the therapeutics that we have available to treat patients with arthritis, MCTR3 was able to both limit disease severity, so the inflammation that happens in the joint, as well as to initiate reparative mechanisms in the joint. So it was able to repair the cartilage or initiate mechanisms to repair the cartilage as well as the bone. And this we found to be extremely exciting simply because now these initial observations suggest that we can target both aspects of the disease, and in particular the damage that occurs to the joints, which results in a reduction in quality of life in patients with arthritis. And so potentially providing an option to improve the severe joint damage whilst also limiting the inflammation that is characteristic of rheumatoid arthritis. So pain is a key aspect in rheumatic conditions, in particular rheumatoid arthritis. It's linked with both the inflammatory aspect but also the joint damage. And there's significant evidence now in the literature that specialized pro-resolving mediators can directly regulate mechanisms within the body's ability to sense pain and and how pain is propagated. So we believe, and the evidence, at least in experimental systems, supports this, that SPMs can provide a new therapeutic paradigm to also reduce pain in a long-term effect by both reducing the inflammatory component as well as by reducing pain sensation both peripherally and also centrally. And so this one could envisage that specialized pro-resolving mediators could be used as co-therapies or adjunct therapies with classic anti-inflammatories like DMARDs, disease-modifying anti-rheumatic drugs, where a patient is treated with potentially lower doses of these DMARDs so you don't expose the patient to the potential side effects that these drugs have, with an SPM. And so together, the DMARDs and SPM can limit the inflammation, but also you can regulate the pain. And as I mentioned, we can also start repairing these damaged joints. So I think this is a very exciting aspect of where specialized pro-resolving research and biology is heading, that we could think of a new therapeutic paradigm where we're able to reprogram immune cells in a long term to be able to regulate various aspects of a disease, which is not what we've been able to do so far. In many of the treatments that we have, we can only target specific aspects of the disease course. But because the SPMs target multiple cells, we are likely to be able to regulate various mechanisms within the disease process. So we have not yet tested combination therapy. This is something that will need to be evaluated as we move forward. However, at least in humans, in experimental systems, this has been tested. It's been tested, for example, in the context of bacterial infections, where we know that with SPMs we can reduce the required dose of antibiotics to limit infection by increasing the ability of the host's immune response to clear the bacteria more efficiently, and in disease settings where you have chronic inflammation. So there is preclinical evidence that this paradigm could hold up in clinical settings. Clearly, we need the human data now.